Yes, friends. Today it has been a hard day for me. Very many things have come late, and it's good that we do something for today. We had a topic that we had to work on yesterday, but because of time, today things have been much here and there. Have been up and down. Have been up and down. Okay, it's connected. Yes, I've been up and down, and that's the cause of me being away. We had to manage diabetes type 2 today. Diabetes type 2. Just a minute. Connect all this. Okay, this here. Okay. Minute. Okay, now we need to manage diabetes type 2 today. Diabetes type 2, and it's important we we go back to the topic of yesterday and see. Yes, we continue to the topic of yesterday. We see what we had left Thursday evening. And, yes, before we learn about diabetes management, type 2 management, we need to go back to the pathophysiology of yesterday. We see, before you know how to manage, you really need to know what is the problem. We remind ourselves on what is the problem in diabetes type 2. So here comes the problem now. You see, in diabetes type 2, we should learn how it comes so that we know how to reverse. Here we remember we were told the genetics and environment predisposition. You remember the resistance of beta cells and the mutation. That is what we are talking about, genetics. And now we go to the other thing, which is insulin resistance. Insulin resistance. You remember how we talked about it? How chronic inflammation brings in tumor necrotic factor and interleukin 6. Yeah? It impairs the function. You get it? Because when you have chronic inflammation, you get impairment of some function. When tumor necrotic factor and interleukin 6, you remember they are cytokines, they are mediators of immunities in the body. When they impair insulin production, what happens? What happens is you get reduced muscle glucose uptake. Eh? Postprandial hypoglycemia. After you eat, your glucose goes up. And then we have liver, inappropriate hepatic gluconeogenesis. Sometimes you have glucose that is produced from your liver, from the glycogen that we stored, that is not necessary. You are fasting, but glucose is coming out so much from the liver. Yeah? And then We talked about adipose tissues, lipolysis. I said wherever you hear about lipolysis, you remember breakdown, breakdown of fats. Worsen insulin resistance and promote hepatic glucose production. Eh, free fatty acids. You get it? Worsen insulin resistance and promote hepatic glucose production. So these are the things we should understand. I know yesterday I went so slow so that you can understand, but before you treat, you see, before you treat, you need to understand the problem. So today we are doing with the management. If we are dealing with the management, let's get to know the problem. The problem here, we said insulin resistance, free fatty acids and adipokines interfere with insulin receptor signaling. So we said at the pancreas, you are having a big body, you have taken a lot of cholesterol and fat, and carbs are making you be big. At the pancreas, you get a layer of fat even inside. So it interferes with the signaling pathway of insulin. When your body is telling when your body, the brain is telling the islands of Langerhans release some insulin. It doesn't release because more fats, free fatty acids are interfering. You get it? So that was the second one, and then we go to beta cell dysfunction. Beta cell dysfunction is beta cell compensate increasing insulin secretion like hyperinsulinemia. Oh, you see, beta cell compensate by increasing insulin secretion. So when you get hyperinsulinemia over time, what happens? Glucotoxicity happens. Chronic hyperglycemia damages beta cells. You get it? Hyperinsulinemia over time. So the toxicity damages beta cells. Lipotoxicity, excess free fatty acids accumulate in beta cells, impairing insulin secretion. You get it? These are the things that make your beta cells to be destroyed. A lot of glucose, a lot of lipotoxicity, isolate amyloid disposition, that protein that we talked about from amylin core secreted with insulin. So the amyloid protein sometimes it can destroy the insulin, beta cell, eh? Apoptosis. It leads to apoptosis, cell death. You remember we talked about cell death, apoptosis. So the beta cells die because of glucotoxicity, lipotoxicity, isolate amyloid disposition. And then we remember the increased hormones in the stomach. This is another problem, increased hormones in the stomach dysfunction. Normally, that hormones in the stomach enhance insulin secretion after meals in type 2 diabetes mellitus. So when you eat, the increased hormones enhance insulin. So insulin enhances production of glucose from the liver. Hmm? You see, when they enhance insulin production, what happens? You have so a lot of insulin in your liver that is producing more glucose to the blood circulatory system, the arteries, the veins, the capillaries, because now you have just taken a little meal, but the increased hormones in your stomach are telling the liver produce more insulin. So the glycogen that you stored is coming out back. It's coming out back from the liver, and you have taken a meal. So you have high glucose. Eh? You see, it worsens. You get high glucose in your system. Please, if you've not gone through the other video, if you want to understand well, check about diabetes type 2 pathophysiology, how it comes. And then we have renal contribution. Kidney reabsorbs glucose via SGLT2 transporter. So your kidney reabsorbs glucose. Glucose is not supposed to be in urine when you are normal, but when you have a problem, you'll get your kidneys absorbing so much glucose. You see, in diabetes, Renal glucose threshold is more, it's high. Renal, when I'm talking about renal, I'm talking about the kidney. You get it? It makes your sugars go high. Eh? Other hormones like lipolysis, ketone bodies, and chronic insulin resistance, these cause to atherosclerosis and cardiovascular complication. People that are diabetic, their veins are so stiff. Then when you try to get a needle, sometimes you'll find it hard and you are seeing them because of atherosclerosis, deposition of some parts. So pathophysiology, how does it come? Before we go to management, this is how it comes. Insulin resistance, beta cell dysfunction, incretin effect reduction, glucagon overproduction, renal glucose reabsorption increase, chronic inflammation, lipotoxicity, and glucotoxicity. Glucotoxicity is toxicity of glucose in your system. Now, yes, we continue with management. Management of type 2 diabetes, 10 minutes of reminding ourselves the pathophysiology. And now we are on management of diabetes type 2. Let's go. Management of diabetes type 2 focuses on control blood sugars, reducing insulin resistance, preserving beta cell function, and preventing complications. I'll repeat very clearly because type 2 is the one that you are not born with. So if the one you are not born with, what do? Control glucose, blood glucose, reduce insulin resistance, preserve beta cell function in the pancreas so that they are not destroyed, and prevent complications like diabetic ketoacidosis, end organ damage, hyperinsulinemia, those conditions that no sugars bring. You make sure you are not getting there by not taking alcohol, not taking a lot of food. You see that? And then, unlike type 1, insulin is not always required immediately, but lifestyle and pharmacologic changes is very important. Now, we get to lifestyle and pharmacologic changes. Lifestyle and pharmacologic changes, modification. First line to all patients of diabetes, diet. Hmm? Diet of a diabetic patient. Let's talk. Let's go. Someone asked me yesterday about diet of a diabetic patient. How do you diet when you are diabetic? Which measures do you take? Wait a minute. A minute. Yes. How do you eat? More carbs will bring more glycerols and glucagon. And you have seen when you're fasting, some glucagon comes out of your body so fast. So, what is your diet? Are you supposed to balance your diet? Let's check. Let's see so that people may understand. Goal of nutritional therapy: achieve near normal blood glucose and HbA1c, hemoglobin. 7% of individuals target 7%, not exceeding 7%. And then improve lipid profile and blood pressure, very important. And then prevent or slow complications. You get it? You prevent or slow complications. Read this now. Now we continue. Now we are talking about achieving near normal. You get it? Improving lipid profile and blood pressure. And then we get to prevent or slow complications. So, support health weight management and promote overall well-being and sustainable lifestyle. Calorie intakes. Calorie intakes, Overweight and obese patient calorie restriction is key. You get it? This is for diabetics. Moderate reduction from 500 to 750 of weight per day. You see, that is like 250 weight loss of 0.1 to 1 kg per week. Every 5 to 10% of weight loss improves insulin sensitivity and glycemic control. Yes, weight reduction for people that are big people. Calorie needs sedentary 20 to 25, moderately active 25 to 30. If you are working aggressive, very active, you will need a calorie reduction of 30 to 35. Hmm? Moderate, normal 25 to 30. And then the other one 20 to 25. You are not so active. Micronutrients balance according to patient's preference, culture, and goals. So, carbohydrate, you should eat 45 to 55% of total calories. Prefer low glycemic index. High fiber foods are very important. Whole grain. Now, this is the deal now. Whole grain. Whole grain, brown rice, oats, whole wheat chapati, ugali from whole maize millet. Those are carbohydrates. Legumes, beans, lentils, green grams. Those are vegetables. You see, vegetables you can starch. Sukuma wiki, spinach, cabbage, and broccoli. Fruits, very moderate portions. Prefer low ones that have low sugars, like apples, oranges, pawpaws, and berries. Avoid limit refined carbs are not okay for you. Refined carbs are not okay. White bread, chapati with refined flour, mandazi, and cakes. Hey, please stop them. Sugar drinks like sodas and juices, they have fructose at high level. You stop them. And you see, fructose is one of the high sugar brands. So you stop them. Fiber, at least 25 to 30 grams per day. Fiber improves satiety and slow glucose absorption. So you know what foods that have fiber. Which foods have fiber? Hmm? Fiber foods. Foods that have fiber are let me see. Because here we are told fiber it reduces improves satiety and it reduces glucose absorption. Hmm? So when I'm talking about fiber food, which fiber foods should you eat? Which of the foods of fiber do you need to eat so that you improve yourself for this? Most of the greens have fiber in them. Greens have fiber, and there are some others that they are soluble fibers and insoluble fibers. We should place them like that. Soluble fibers and insoluble fibers. Dissolved in water. Soluble fibers are dissolved in water are gel-like material. Slow digestion and help lower blood cholesterol and glucose levels. Found in 1. Oats, 2. Apples, citrus fruits, beans, peas, barley, carrot, and psyllium. So those are fibers. Fibers. Fibers are oats, apples, citrus fruits, beans, peas, barley, carrots, and psyllium. And these are types of soluble fibers. And then we have insoluble ones. Insoluble ones are bulk to stool and help food to move through the digestive system. Found in whole wheat flour, and then we have nuts, beans, cauliflower, greens, and potatoes. Now, those are types of fibers that you should be using. And then we have protein, improve satiety, prevents muscle wasting. Sources, lean meat, skinless chicken. Chicken, you take chicken without the skin. Hmm? Fish and goat. Fish and goat. You take fish and goat. eggs, low fat milk, legumes. Avoid excess protein in diabetic nephropathy. You get it? Diabetic nephropathy is when you're feeling burning sensation in your legs. Yes. So you don't eat excess, it will increase. You get it? Hmm? If CKD is there, CKD is chronic kidney failure. You don't eat a lot of that fat, the protein. Now let's get to fats. 25 to 35% of total calories. Focus on quality of fat. Prefer unsaturated fats like monosaturate oil, olive, avocado, and ground nuts oil. Hmm? Polyunsaturated omega-3 is very important. You see, fish, fingerlings, omena, sardines, yes, tilapia, and seeds. Those are very important foods for the body of a diabetic. Limited saturated like fatty meat, butter, and cream. Avoid trans fats like margarine. Processed snacks are not good for you as a diabetic. Now we go to meal planning. Meal planning, if you have a pen, this is now where you really need to write down meal planning of a diabetic person. Meal planning. Here, plate method. A half plate non-starch vegetables. I've talked about them. That's why I've gone through all those. So a half a plate of non-starch vegetables, a half a plate of non-starch vegetables, a quarter plate whole grain or starch vegetables, normal plate that we use, or starch vegetables. And then we have a quarter plate of lean protein. Hmm? Carbohydrate counting useful in on your insulin. So you should do some starch, a little bit of starch. So here we are talking a lot of vegetables, vegetables, vegetables. You get it? And lean protein. Starch is very minimal for a person who is diabetic and you want to cut weight. This is what you should be eating. This is a meal plan. Hmm? So when we talk about it, we talk about we prefer low carbohydrate low carbohydrate meals. That's why we are talking about protein and vegetables. You check it out about where I started. You will know low GI foods. Margarine, processed foods, and snacks are not good for a diabetic person. Margarine, those you know, the processed one that have a lot of fructose, like the other one which is called butter. Yes. Portion control, small quantity of meal, avoid overeating. Even if you are feeling to eat and eat whatever I've said. A quarter plate non-starchy vegetables, a quarter plate whole grain and starchy vegetables, a quarter plate of lean protein. Someone asked me, Doc, you're telling me to eat well and I don't have finances. Now, you know how to eat. Here, non-starch vegetables, getting vegetables is not a big deal. If you have somewhere, the rurals, you can plant good. In Kenya here, someone can get vegetables even with under 10 shillings. That is like 0.0 something a dollar. You get it. So I've said this is the a meal planning for a diabetic, for also a person who is obese and wants to cut weight. And when we started, you saw the program of cutting weight. For sedentary, don't cut weight once, pap. No. I said for a person who is not very active, 20 to 25 kilocalories or kgs per day is important. For a moderate active, 25 to 30. For a person who is very active, cutting weight of 30 to 35 calories per day. That is very minimal. 30 to 35 kilocalories per day is very minimal. The act of going for lipos and some surgeries to cut weight at times are not good. Mostly when you are diabetic, it's not good. you have to have a tapering off so that insulin can be produced accordingly. If you cut weight once, you may temper with the beta cells again. So that is it about the eating product meal planning of a diabetic. And then we have something called micronutrients and supplements. Micronutrients and supplements. Emphasis on vitamins. If you are watching and you have a question, please place it there so that I can refrain. Please press it there so that I can go deep on what you are not understanding. Yes. Emphasize vitamins and mineral rich foods, fruits and vegetables. I've said the fruits that you should be eating, like apples, you see, those that have low fructose. And then we go on and say non routine supplementation unless protein, deficiency presence. If they are not there, it's okay. But the fruits, if they are there, please eat them. Alcohol, if taken, if you are taking alcohol, because sometimes you'll tell people don't take alcohol, hmm, and they will go and drink. So you limit your alcohol taking by 1 drink per day for women, and for men 2. But make sure you are taking it with food. Make sure you are taking it with food. But if you can avoid alcohol, it's the better. Sodium restriction, 2,300 and 300 milligrams per day, less if hypertensive. So if you are diabetic and you are hypertensive, should very little salt is important. Very little salt. 2,300 milligram is very little salt. So you don't take a lot of salt when you are diabetic. Yes, we see cultural and practices adaptations like replacing ugali from refined flour with milk. Mm? Use brown chapati whole instead of white. Replace sodas, juices with unsweetened tea. Mm? Encourage traditional legumes like beans, lego, and jahi. Those ones are African. Eh? Then monitoring and support. Now that is about nutrition and about nutrition. That is about what you should be eating. Exercise. Exercise. At least 150 minutes per week of moderate anaerobic aerobic activities, res- resistance training 2 to 3 times a week. Let me get to that again. 150 minutes per week of moderate aerobic activity, resistance training 2 to 3 times a week. You get it? This is you are when you want to train to exercise. Sometimes excessive training may mess up your insulin production. So for people who are obese or have big bodies and you want to work out, at least you start with 150 minutes per week. Those are how many hours? 2 hours of moderate aerobic activity. As you increase resistant training, carrying weights, and so 2 to 3 times per week. So in a week, if you do it on Monday, you can repeat on Friday. If you do it on Wednesday, you can do on Saturday or Sunday training. But for aerobics, you can do twice a week for 2 hours. Aerobics, you know, understand aerobics. Aerobics are the dancing treadmill. So you can do them for 2 hours, but per week, not daily of aerobics. Because when we started, we said if you do more of aerobics, what will happen? Insulin from beta cells will be a problem. It causes insulin resistance. So there is a way you can excite insulin production by doing some exercises, and that is the program I'm giving. Yeah, this one will reduce insulin resistance and improve cardiovascular health. You get it by doing this exercise. So you remember, in a week, 2 hours of aerobic and weight carrying, the weight carrying, weight. Those are called resistance training for 2 to 3 times per week. We don't want you are diabetic, you are trying to exercise, and you are now helping yourself to get insulin resistance while working hard. And if you go to a gym that there is a person who understands medical fitness. Yes, not just aerobic to bodybuild. Yes. Now, there are some things you need to stop or to regulate, like cigarette smoking. You should stop. That one is not an idea of talking ABCD. You should smoke cigarettes, you stop cigarette smoking, reduce alcohol intake, and stress management. You saw how stress happens when you are diabetic type 2. Now, we go on and pharmacological therapy. Stepwise approach. First line, drug is metformin. Metformin is a binguanide. This binguanide, you saw how it works. It stops overproduction of glucose and enhances insulin production. You see, unless contraindicated, severe renal impairment sometimes when you have problems with your kidney, you should not use insulin, metformin. Sorry, you should not use metformin. It will destroy your kidneys. So you check on your doctor wherever you are, and if you are a doctor you or a health worker where you are, you help your patient to know if he should not use metformin because it's always the first line. It enhances insulin production and reduces insulin the glucagon production. So now we go on. Improves insulin sensitivity, reduces hepatic glucose production. Yes. Side effects is lactic acidosis at times, but not so much, and then stomach upset because of the increase. Now, we have the second line drugs that are called um, GL, the increte protein receptor antagonists, the GLP-1 receptor antagonists like semaglutide and iraglutide. Promote weight loss, low risk of hyperglycemia and cardiovascular and renal protection. These ones mostly they enhance glucose from the renal system to be excreted, not to be reabsorbed from the kidney. These ones. So if they are not, you are not reabsorbing, if you are not reabsorbing glucose, body-wise you will be sleep. And then we have SGP inhibitors, glucose 2 inhibitors, SGLT2 inhibitors like empagliflozin, dapagliflozin, and canagliflozin promote glucose loss in urine and weight loss, BP reduction. So these ones are good because they are taking care even of your pressure. You see, these ones I think they are the best. Second line, they are the best. But you see, this one you add if HbA1c remains above the target of 3 months, so that we enhance glucose removal. Yes, yes. Mwambia ngoja. Ni mgani yo? Sawa, chukua Vitos. Ana shida gani? Sawa, mwambie dakika moja. Now, these ones are, let me see. I've been called for an emergency. Let me come. Let me come. Sorry, you have to go. Yes, guys, sorry. I got an emergency and I had to save a life. I had to save a life somewhere. I think I'm on course. Hi, Mumbo. Sorry about that. It was an emergency, and you see, if you are a doctor, you need to save life. So I've just saved someone. Now, we continue. Yes. Now I we continue. We continue now. We were at the pharmacological therapy. Pharmacological therapy means, and it means that we are dealing with drugs. As I had said, first line is metformin, and after metformin, we go to second line, which is the ones that we have said they make you lose weight a lot. The GLP-1 receptor antagonist and SLTP2 inhibitors. Now, what is GLP-1? This is the second line drugs, but we need to understand when I'm talking about GLP-1 receptor antagonist. Someone may ask me like, Doc, we are just talking about things that we are not understanding. Hmm? People should understand these drugs well and what they do, because when you take drugs or some drugs, you need to know what they are doing to your body. You see, the first line we said metformin. This is for the people who are type 2 diabetes. The first line is always we give metformin. What metformin does, it reduces glycogen to be broken down from the liver to come to the normal systemic circulation. You get it? And it increases insulin sensitivity. Insulin sensitivity, which means when you have just eaten food, the increte hormones like GLP-1, this one that I'm saying, DLP, what is this doing? Sorry. it increases its sensitivity. You get it? So you you can like remove insulin that is dealing with the food that is eaten. Now we continue in yes, Dorothy, you go deal with si umlete alale hapa. Dorothy, sometimes when I'm online you take some responsibility. Go. Now you see when we look at some issues, interruptions today are so much. Don't worry guys, let's continue. And we check now. We check at this is GLP-1, glucose like peptide 1, glucose like peptide 1. This is it's called an increte hormone. An increte hormone is a hormone that tells insulin to be removed from the beta cells to come and help sugars that are high. So GLP-1 as an increte hormone secretes by L cells in the small intestines. It is removed from the cells of your stomach. You get it? So when I'm talking about GLP-1, it is glucose like peptide. It likes glucose. When you just take food and it senses that there is glucose in your body, what do? You 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 know insulin comes out. Now we continue here. I've explained what is glucose like peptide 1 receptor antagonist drug. And we have said, one, it promotes weight loss, low risk of hypoglycemia. Yes, and cardiovascular and renal protection. It protects your heart. It protects your heart. And then we have SGLT2 inhibitor, empagliflozin. I've seen so many people taking empagliflozin. And when you're taking empagliflozin, what do you get? Most of the time, you get weight loss. You get weight loss. You reduce in weight. Let's go. You see, empagliflozin is sodium glucose cotransporter 2 inhibitor. Sodium glucose cotransporter 2 inhibitors. You see, for you glucose to go to the mainstream, for glucose to go to the mainstream, it has to have a cotransporter. A cotransporter is something that will carry that glucose from the random production or the normal systemic circulation to go to inside. You see, from the stomach, sorry, is that will go to the stomach, from the stomach to umeshazima hiyo nebulizer. Kwa nini? Si umlete hapa Dorothy. Sometimes you talk to your patient. Yes, I'm back here. But there are some issues I'm taking care of. There's a problem. That's why you are seeing me on and off here. Someone can wait online. I finish. It will be okay. But let me finish with the emergency. Then I'll come back and continue with it. If it will be, but if I'll not make it, I think we'll do another one tomorrow. Yes, let me finish this because we had left a few things to do. Then I'm very sorry about what happened today. I had to take that. I had to do that. Now we were on second line drugs. The sodium glucose like two, the hormone itself, sodium glucose transporter. I was explaining about the sodium transporter. You see, for glucose to go in, go in in the body when you've taken food, it has to have a co-transporter. So the transporter itself, the co-transporter itself, it carries the sugar and the sodium. Sodium carries glucose intracellularly. So if you have something that will stop the binding of sodium to sugars, what will happen? What will happen is there will be no transportation of glucose intracellularly. So that's why we have this drug called empagliflozin. This is sodium glucose cotransporter 2 inhibitor. It inhibits glucose from your your stomach to go inside your your systemic circulation. So this is what happens. When you take empagliflozin, it binds to sodium. So there is no glucose that will be transported intracellularly, and that's why we have these drugs called sodium glucose transporter 2 inhibitor. Hmm? A class of oral antidiabetic drugs. You see, we have like empagliflozin, debaclozil, canaglozil, and etuglozil. These are drugs that bind to sodium, and then you get what? You get there is a break between the bonding of sodium to, you get it. The second mechanism of action in the proximal convoluted tubule of the kidney, in the in the proximal convoluted, this is happening in the kidney. Glucose is normally reabsorbed via sodium glucose like 2 transporter. So in diabetic, the renal threshold of for glucose is elevated because you absorb glucose so much in the and remains in blood. The glucose in blood becomes high. So I think this topic we should repeat it. What's the time? It will be repeated because we have so much disruption today. I'll end there this and we will do it because today it was not a good day for it. Let me end there. We'll talk later.